This conference will now be recorded.
A very good evening to one and all present here. I, Bharti Fatnani, on behalf of Biosetup Life Sciences, take this honor to welcome our founder coordinator, Aragyadeep Das sir, our today's resource person, Dr. Dimitrios Kantas, our event coordinators, Dr. Arpana Parihar, Dr. Ritu S. Shandal, Dr. Sudeep Das, Dr. Shubhendu Bandyopadhyay, and all my dear participants. I welcome you all to international webinar on sleep apnea, cardiovascular disorders and CPAP use organized by Biosetup Life Sciences. Dear participants, please keep your mics turned off. Now let me start by
Yeah.
introducing our
So,
organization, Biosetup Life Sciences. Just a minute, sir. Biosetup Life Sciences is a hub for scientific research and learning approved by ISO 9001-2015 certified and MSME Government of India registered organization having a multidisciplinary team of faculty and research associates that provide support to aspiring students in life sciences. We have successfully organized many workshops, certification courses, career counseling, and competitive exam preparation, such as CSIR, IIT JAM, GATE B, IISc, and DBT. We are continuously working for the career upgradation of the students. Now, just a little housekeeping before we get started. Please do not share your audio, video, or screen to avoid any kind of disturbances. If you have any questions during the presentation, please type them in the chat box. I'll bring them up after the presentation and we will also have time for the discussion at the end. Now, I request Dr. Subhendu Bandyopadhyay sir to kindly proceed further with the program. Over to you, sir.
thank you,
Thank you.
Bharti. So, am I audible?
Yes, sir.
Okay. So, mm, so today's seminar is on a very important topic, that is sleep apnea, cardiovascular risk, and PAP treatment. Now, very recently, those who are from this particular continent and from mainly India, you must have heard that our very popular singer and music director, Bapi Lahiri, just died a year before, and his cause of death was declared as sleep apnea. So, this particular disease is a silent killer, and there is not much awareness about this particular disease. So from that particular point of view, today's seminar is a very interesting one. Now I would like to talk about our very distinguished and esteemed speaker, Dr. Dimitrios Kantas. Now he has graduated from Medical School of Ioannina, Greece, and he then pursued a fellowship in pulmonary and critical care medicine and University Hospital of Ioannina, and then again 1 year fellowship in pulmonary and sleep medicine at University Hospital Birmingham, UK. He also received a MSc in sleep medicine from National University of Athens, Greece. Now, Dr. Kantas is a European fellow or collaborator at Mayo Clinic in Rochester, Minnesota, and PhD candidate working on an RO1 rant and sleep CV risk and racial differences. He is a secretary of Group 4.01 ERS Sleep Assembly 4, member of the PAC Advisory Panel, Young Investigator Forum, and Board Review Committee of AASM and serves as international ambassador of AASM for Europe. Furthermore, he is member of the Diversity, Equity and Inclusion Committee of SRS. Also, he serves as associate editor of the REM section of JCMS, and he is member of the editorial board of Natural and Science of Sleep. He is a member of the European Sleep Research Society, Hellenic Sleep Research Society, World Sleep Society, and British Sleep Society. So, sir, here we welcome you at this particular webinar, and we are eager to hear from you. So, the stage is now open to you. Please, sir.
Okay, I'm really delighted for the kind introduction. I really appreciate that you talked to me. Thanks for the good words. You talk too much. I'm really flattered. Also, I would like to tell you before I start that I really admire your culture and the civilization. You know, the Indian civilization. I'm a guy who really likes history, and I really like your civilization. I have many friends of India in UK and in United States, and I would like to tell you that you are really good people, and I really enjoy be friend with you. So I'm sorry for the background. I have an old computer at the moment. I'm in Greece for holidays, unfortunately. But most of the slides are fine. You may have a problem with a background in the headlines, but that won't affect my my presentation. I'm really sorry about that. Today's talk, as your friend mentioned, is about sleep apnea and cardiovascular sleep. I would talk briefly about. I don't have any disclosures. I would talk to you briefly about sleep apnea and severity grading. I would talk to you about cardiovascular outcomes in sleep apnea, treatment, prevention, primary and secondary. And, you know, there is a hot topic in positive pressure in heart failure, you know, the use of CPAP and BiPAP and servoventilation in sleep apnea. So I will talk to you about that. Now, regarding the severity grading, before I start that, I would like to tell you that, you know, a brief talk about sleep apnea, that, you know, sleep apnea is divided in central and obstructive. Obstructive sleep apnea is when we have a block in the airway during the night for more than 10 seconds, and that's an obstructive apnea. When we don't have a respiratory effort, that's central apnea. So we have that division, obstructive and central. And also the severity grading is that normally people in 1 hour they have till 5 apneas, so that's normal, either central or obstructive. 5 to 15, it's let's say mild sleep apnea. 15 to 30 apneas per hour at night is let's say moderate, and more than 30 is severe. So that's like a brief introduction in order for you to understand what I'm talking about. So regarding the severity grading of sleep apnea, I'm talking both of central and obstructive. It has been shown that stronger association with cardiovascular disease incidence and mortality, mostly in people with severe, as I told you before, more than 30 apneas or hypopneas. You know, hypopnea is when we don't have, let's say, complete collapse of the airway. There is some air moving into the lungs, so that's called hypopnea. Let's say it's not when we don't have apnea, complete block, then we have hypopnea. So we have more, let's say, more severe disease when we have an apnea-hypopnea index of more than 30. Apnea-hypopnea index is a measurement of how much apneas we have per night. So as I told you before, more than 30 is a severe one. So also overnight hypoxemia is an important confounder here. I mean, people who have saturation during the night less than 90, and especially the time that you have less than 90, I mean, people with the drops, as we call them, during the night, and how much time you spend lower than 90% of your saturation. That's an important factor that may cause you cardiovascular morbidity and mortality. And also phenotyping, that's a new topic. You know, it runs in bibliography. When I say phenotyping, is things like your sex, your race. I'm working on that on my thesis. I'm talking about the loop gain and many other things, genotyping, proteomics, genomics, etc. All those factors that may affect a person as an individual. So regarding the mortality, when we start and we talk about cardiovascular risk, we start with mortality. It has been proven that OSA is obstructive sleep apnea. It causes a 2.5 increase in mortality and higher cardiovascular incidence. In this study, MESA study, it's a well-known study in heart disease. Among men untreated with severe OSA, we see that 3%, 3 times increased risk of fatal cardiovascular events compared with people with untreated patients with mild or moderate severe or moderate OSA. What I want you to understand here is that people with severe sleep apnea are people who really have the problem. We don't have, clues for mild or moderate. Probably it causes disease, but we haven't proven that so good. And on the other hand, we don't know if treatment really helps them. I'll show you later. And also among women, the mortality rate, as we see, was 3.5-fold higher in severe untreated OSA compared with female controls. So as you see in both sexes, OSA plays a role. This is an old study, it's from 2005. I always use it in my presentation. So what you see here, I'm sure that you see the cursor of my mouse. So you see that people with, you see controls with green, snorers, mild OSA, severe, it's OSA, and OSA with CPAP treatment. So you see cardiovascular fatal events and non-fatal events. As you see here is people with severe OSA. In both diagrams, you see that they really have increased fatal and non-fatal cardiovascular events, people with severe, as you see here, compared to people who have mild or moderate. And you also can see that people who are treated with people who are treated with CPAP here in blue, let's say, people, they have a lower risk compared to the others. You see in both here. Also, they have the snorers. People who snore, snore is normal. 40% of the population snore, but it seems that snoring, a lot of snoring, loud snoring, and for the whole night snoring isn't the best thing. So it may affect our heart through many mechanisms. So regarding the mortality, this study, the Wisconsin sleep cohort study, as you see, it showed a threefold increased risk of all-cause mortality in people with OSA compared with people without OSA. It has been shown here, especially people with severe OSA, more than apnea-hypopnea index of 30 per hour. They really have a problem, as you see here in the Kaplan-Meier study. Also, another study showed that apnea-hypopnea index of more than 30 predicted a almost 50% increased risk of all-cause mortality in men less than 70 years old. That's the Sleep Heart Health Study, another big study on the topic. Also, we have to talk about prognostic factors, right? Prognostic markers, I'm sorry, like every disease. It seems that I told you before about apnea-hypopnea index, but it doesn't seem that it helps a lot. I mean, apnea-hypopnea index is something that, one size doesn't fit all, as we always say in medicine. So apnea-hypopnea index did not predict mortality in all patients. And it seems that people with, I mean, people, as I told you before, with a time of oxygen desaturation less than 90%, they seem to better phenotyping people with increased risk of mortality. Also, patients with a nocturnal hypoxemia had a twofold increased risk in the sudden cardiac death. And this is mediated by the inflammatory markers, you know, the over-inflammation of the body, oxidative stress, and sympathetic nervous system activation. During the night, when you don't sleep so well, I mean, simple thinking, you have a serious problem, and that increases your stress, either inflammatory stress or your sympathetic stress. Also, other sleep diseases like PLM, periodic left movements, number of awakenings, a short sleep time. I mean, it's been proven that people who don't sleep so much, who wake up during the night, or who have this disease called periodic left movements, it seems that they have increased risk of cardiovascular events. It has been shown that cardiovascular sudden cardiac death, we find it almost in 50% of OSA compared with controls. I mean, we see double risk, right? 17 times increased risk in arterial and ventricular arrhythmias. Also, short sleep duration, sleep fragment sleep, you know, variable sleep wake patterns increase the risk of morbidity and mortality. As we said before, when I say variable sleep wake patterns, I mean shift workers, you know, people who work during the night, they wake up during the day, or their working schedules is that kind that it doesn't allow them to have a fixed sleep pattern. Another important factor is hypertension. I mean, 50% of OSA patients may have hypertension, and 30% of hypertensive patients may have OSA. Remember that 50% of the population with hypertension, they have a comorbid OSA. It's a cure, half of them, right? Untreated OSA increases the risk of developing hypertension almost 2 to 3 times. And also, untreated OSA is a cause for resistant hypertension. You see here the recent guidelines, the European Society of Cardiology. They have sleep apnea as a causes of resistant hypertension. So always remember, you have a patient, you cannot treat the hypertension. You need to focus on sleep apnea apart from the other factors. Regarding hypertension, a randomized control trial of 3 months of CPAP versus nocturnal oxygen and controls. CPAP was shown to decrease the blood pressure of 2.5 millimeters of mercury, especially at night, right? Several meta-analyses have shown the same blood pressure decreases. It has been shown that lowering blood pressure at night compared to daytimes was mostly seen in people who were sleepy, adherent to CPAP, and higher apnea-hypopnea index. You can understand that people who are in worse condition, they have been shown to improve with treatment. And also, 2 meta-analyses in CPAP treatment to resistant hypertension have been shown that they decrease systolic and diastolic blood pressure 5 and 3 millimeters of mercury, respectively. There is a variation, as you understand, in that how the studies are organized, and what kind of population we have, the country we work. Here is the study I mentioned before. I'm sorry. Oops. Here is a study I told you before. You see here the change in blood pressure, systolic and diastolic pressure. You see people with placebo, black box, CPAP here, and with oxygen. And you see that obviously people with CPAP, they decrease their blood pressure, right? As we mentioned before, it's about 5 millimeters of mercury Depending people with resistance here, they have they improve more with CPAP. It has been shown here, especially with systolic blood pressure, less of diastolic. Obviously, CPAP is better than nothing, and it seems that oxygen doesn't improve so much because the main problem of those people is awakenings, right? I mean, you can improve your oxygen saturation with oxygen supplementation, but what about awakenings from OSA? So that can be fixed with the CPAP that improves both oxygenation and awakenings. So now regarding arrhythmia and atrial fibrillation, OSA causes structural changes in both atrials, conduction abnormalities, and without any changes in atrial refractoriness. OSA may also increase atrial fibrillation, triggering inflammation in the pulmonary veins. And obstructive respiratory events during the night may cause electrophysiological arrhythmogenic changes. In this study, varicose OSA, the nights with more severe sleep apnea conferred a twofold increase of risk of more than 1 hour of atrial fibrillation during the same day compared with the best sleep nights. I'll show you later what I'm talking here. So, sorry. So here is the abnormalities that OSA causes to atrial fibrillation. I mean, from negative intrathoracic pressure changes, cyclical desaturation and reoxygenation, and sympathovagal activation, we have acute problems and chronic problems. Regarding the acute, in the atrium, we have decreased refractoriness, decreased conduction velocity, increased triggers, and in the vertical, we have prolongation of QT and increased triggering of premature beats. Regarding the chronics, which are the most important, as you see, it's in the atrium. Sorry? Oh, in the atrium, it causes atrial dilatation, which is the most important factor for chronic atrial fibrillation. Causes fibrosis, conduction abnormalities in the vertical, hypertrophy, and heart failure. As you see here, the arrhythmogenic risk from transient apnea associated peaks from the acute phase. In the chronic phase, we have the structural damage to either atrial or ventricle, and those problems cause long-term sleep apnea and cardiovascular risk factors. Now, this is a study I talked you before, the Variosa AF study. So this is a study that it has shown that during the night, all patients aren't the same. You have between the nights. I mean, if you have a patient, each night isn't the same, right? I mean, you sleep one night might be better than the other one. So that difference in how you sleep during the night may increase or decrease the risk of atrial fibrillation compared to how much sleep apnea you have during the night. So you see here that people with, let's say, almost a quarter of days with atrial fibrillation more than 1 hour, right? They have AF here, quarter of the night, right? Here with 40% of the night in people with moderate to severe OSA. So the worse the OSA, the more AF you have. Also here, we have the same patient during 100 nights. Like you see here that every night isn't the same. Here you have for 1 hour atrial fibrillation. Here it's day 11, day 19, day 23, 25, 30, and you see as time passes, you see that these people is getting really worse. Here you have, for example, an episode of almost 6 to 7 hours of atrial fibrillation during the night. Try to imagine how that affects his overall health and that's paroxysmal atrial fibrillation, right? It's not chronic. So people, if they have OSA, that will goes worse during the days to come and the years to come. So it's getting worse and worse. That's the main problem of those people. Also here, you see that RDI is a respiratory disturbance index. Let's say it's something like apnea-hypopnea index. So you see that the number of the days this person has with OSA, as it goes from mild to severe disease, you have more and more days with OSA, and I mean here you have a person with almost 5 apnea-hypopnea index, and here is 20. You see how many days he has with OSA compared to here. Also, atrial fibrillation, my second slide. The prevalence of sleep disorder breathing. When we say sleep disorder breathing, is OSA, central sleep apnea. In patients with atrial fibrillation is higher compared with people without AF. So sleep apnea causes atrial fibrillation. On the other hand, atrial fibrillation also causes sleep apnea. Severe OSA is associated with lower response rate to antiarrhythmic drugs, and patients with OSA have 31 greater risk of AF recurrence after pulmonary vein isolation. We call that ablation. I'm sure you are aware of that. So always remember, you have a person, he goes for ablation, repeated ablation, doesn't respond to ablation, what's going on? Search for sleep apnea. It's important. Also, CPAP was associated with lower AF recurrence after cardiovasculation in pulmonary veins, and meta-analysis has shown that CPAP was associated with a 42 decreased risk of AF recurrence. I mean, what I told you before, it's been proven. Think about that. Also here, you see a meta-analysis of studies that has been shown that CPAP treatment, this meta-analysis favors CPAP use compared to no use. You see most of the studies show that there is an improvement. This is a large meta-analysis. AF may predispose to 100 change stocks breathing. You know, change stocks starts, it accumulates, then it's waxing and waning respiration. I'm sure about you know about that. And it's not just change stocks; it's Hunter change stock. It's Hunter who first described it. If you really like history as much as I do, search about it and you will learn more. It predisposes to pulmonary to Hunter change stocks breathing through pulmonary vascular pressure triggering hyperventilation, hypocapnia, pulmonary vagal irritant receptors, and many other mechanisms. Change stocks breathing may increase the prosperity to fibrillation by hypocapnia and electrical instability. Also, autonomic dysfunction may predispose to both change stocks breathing and atrial fibrillation, as can be found in idiopathic change stocks breathing. So now, regarding vertical fibrillation, you need to understand that the mechanism is, let's say, the same. Thoracic pressure swings plus sympathetic activation increase the risk of sudden cardiac death in OSA. When we say pressure swings, try to understand that these people, they do something like the Müller. They try to inhale and with a closed upper airway. So the Müller maneuver, as we call it. An apnea-hypopnea index of more than 20, let's say moderate to severe, it's an independent risk factor of sudden cardiac death, as we said before. Severe OSA may also increase the risk of ventricular premature beats and non-sustained ventricular tachycardia and sudden cardiac death. There is a lot of debate here, and I'll tell you why. Treatment for change stocks breathing with servo ventilator, servo assisted ventilation, it's a new treatment. let's say it's not like CPAP and BiPAP. It's something in between. You have a better machine. It follows the breathing pattern of the patient. When the patient decreases the breathing pattern, the servo ventilator is increasing the help it gives to the respiratory system. On the other hand, if the patient is back on ventilation, the oscillation of the ventilator, of the servo ventilator, decreases. So you have that pattern. It's more friendly, patient friendly, and that's why we like it. But it has a certain problem. In this randomized controlled trial from 2015, servo ventilator has been shown that has been proved that in people with a severe heart failure with a ejection fraction less than 75%, 45%, sorry, 45%, it causes, it increases mortality. So that's why there is we have a problem with a servo ventilator in people with severe OSA. We don't give it to people with severe heart failure. After adjustment for traditional risk factors, OSA was associated with a default increased risk in cardiovascular death or cardiovascular disease. Undiagnosed severe OSA in patients with ST segment elevation myocardial infarction was about 40%. So people with OSA have, let's say, worse myocardial infarction with elevation of ST segment, and also people with OSA were far more likely to have their myocardial infarction during nighttime. And you can understand that due to desaturation, autonomic nervous system activation. So that's a major problem. So OSA is a major factor of coronary artery disease. Apart from the other factors, we need to focus to sleep apnea as well. Coronary artery disease, right? Here is the May study. You all, I mean, the cardiologists and most of people who work in cardiovascular disease know May study. OSA affects cardiovascular risk through hypoxemia and excessive daytime sleepiness. So people who are symptomatic due to their sleep apnea, they are worse compared to the others. As you see here, patients with OSA have increased arterial stiffness, atherosclerosis, coronary artery calcification, and coronary plaque instability and plaque vulnerability. Severity of coronary artery disease was increased in those with moderate to severe OSA, right? People, as we said before, with severe OSA, as let's say the worst compared to the others. As I told you, we haven't proved yet that CPAP helps people with mild to moderate severe OSA. Relationship between hypoxemia and obstructive apnea and ST segment changes, not just elevation, but also other kind of problems with the ST segment changes, and chest pain, waking a patient from sleep. All this symptomatic, as I told you, people have a severe problem. As we said before, it's not apnea-hypopnea index per se, but it is the severity of nocturnal oxygen desaturation that appears to mostly predict the development of nocturnal ST segment depression in OSA patients. So as we call it, the myocardial strain. Again, the May study, OSA is associated with increased mortality after a myocardial infarction, which is, of course, we all know what's the treatment for MI with ST segment elevation. It's coronary intervention. The sooner the better. OSA was independently associated with increased risk of MACE, major cardiovascular events. OSA after PCI was found to increase the risk of MACE. Also, regarding heart failure, sleep disordered breathing, OSA, central obstructive sleep apnea is common in heart failure patients, right? You see here 50 to 75%, more than half of your patients with heart failure have OSA as well. And in acute heart failure, the presence is between more than that, it's more close to 100% for many mechanisms. Many mechanisms lead us to that problem. Strong association with sleep disorder breathing and obesity, male sex, atrial fibrillation, age, LV dysfunction. The prevalence of central sleep apnea increases as the symptomatic severity of the heart failure increases. In the early stages of heart failure, you have OSA. In the late stages of heart failure, you mostly have central sleep apnea, and they both overlap. And the severity of the sleep apnea minors underlying cardiac dysfunction. As you understand, sleep apnea is independently associated with increased mortality in people with heart failure. So here, another study. You see here the percentage of survival, a Kaplan-Meier study. You see here that people with apnea-hypopnea index less than 5 per hour, this with the blue, they are far better compared with people with apnea-hypopnea index equal or greater to 5 per hour. And we are close to the normal. As I told you before, you see the hazard ratio here is 2.1, which is statistical significant. So you see people that they are, let's say, close to the normal. 5, as we said, is the normal, 5 apneas per hour. So people with more than 5 apneas per hour, there are far worse people who are, let's say, normal, close to 5. You see how this affects the survival, especially in people with sleep apnea. You see here central sleep apnea as a predictor of mortality. So it's very important in those people with heart failure, central sleep apnea. Always in people with heart failure, think of sleep apnea, either central or in more severe cases, central. Hypoxemia during episodes of ISA, they cause pulmonary hypertension due to hypoxic vasoconstriction, and as you understand, it increases mortality. We see that the prevalence of pulmonary hypertension is 20%, as you see here, and the meta-analysis of 6 small studies have shown that treatment causes a very mild reduction of only 1.3 millimeters of mercury of pulmonary pressure. You see here people with the overall survival, another Kaplan-Meier study. You see people with pulmonary hypertension, they are far worse compared to people without pulmonary hypertension and OSA. Here another study, you see that CPAP with no active intervention, I mean, people who CPAP did not result in a reduction in the incidence of hypertension and cardiovascular events. You see a study here claiming that they haven't seen any event, but they have shown some kind of event with the CPAP use. So these people claim that people who are adherent to CPAP, and when we say adherent, we mean that they wear their CPAP machine more than 4 hours per night for let's say 5 to 6 days per week. So those people are really helped from sleep up. And you see here this study, CPAP versus control. People, I mean, they haven't shown anything. It's 0.8. They adjusted risk. But people who were adherent to CPAP, you see people here who were adherent, here people who weren't adherent. In people who were adherent, you see the decrease in the risk of an event compared to people who weren't adherent. So it's 1.2 for 0.69, and this doesn't cross 1, so it really helps. And it is statistically significant. So here, another study, CPAP showed the improved hypertension control and sleepiness, but cerebrovascular and cardiovascular disease were unchanged. So this is different way of design the study. So not all studies have shown what we expect, but it seems that CPAP helps people, especially people who are compliant. Secondary prevention, after you get your stroke or your myocardial infarction, use of CPAP did not significantly reduce the primary composite endpoint of May subgroup analysis. But also here they have shown the same, that people who are adherent more than 4 hours per night had a lower risk of stroke and total cardiovascular events. Another study, Ricardosa, this had patients non-sleeping with moderate to severe OSA, moderate to severe, not severe, that's important, were randomized to CPAP or a coronary or control after PCI. CPAP group showed no change in cardiovascular endpoints, but for another time, as we said before, good adherence to CPAP showed that they have lower cardiovascular risk. As you see here, the study hasn't shown any major difference, so people are quite the same with CPAP and control. So people who use CPAP and they are compliant, let's say they are going better compared to the controls. Another study, ISAC study, examining patients with acute coronary syndrome and with moderate to severe OSA. CPAP had no significant effect on the primary composite endpoint, but as we said before, CPAP users did have an improvement in hypertension, daytime sleepiness, so they went to a more symptomatic phenotype. Regarding treatment summary, as we said before, we have same study, Ricardosa study, and ISAC study. For people with a cardiovascular disease, their apnea-hypopnea index were moderate to severe. The primary intervention was CPAP versus control. You see the follow-up, which was enough. The hazard ratio, which was close to 1, so it didn't show any improvement in those groups, but in people who were adherent, you see that in all 3 studies, we see that there is a major improvement in their cardiovascular risk. This is the daytime sleepiness at baseline. So those people, the Epworth sleepiness scale is a scale that we measure sleepiness. So more than 10 is people who are sleepy. So let's say symptomatic, people with cardiovascular problems and symptomatic. Here we have a meta-analysis of 3,000 people, more than 3,000 of CPAP to usual care, no improvement in survival. Unfortunately, we haven't found anything in this meta-analysis. There is a debate in people with OSA and how this affects many studies. I would say that it helps, especially with good compliance, as we said before. Now, another major topic is positive airway pressure, as I told you, in heart failure. So we have this randomized control trial, nocturnal CPAP for 3 months. It showed that improved LV ejection fraction and reduced urinary norepinephrine exertion. So it shows some improvement. Another study here that CPAP improved right ventricular fraction, as we said before, LV mass, pulmonary hypertension, and this persisted at 1 year. We have also a higher rate of hospitalization and death in non-CPAP group compared to those who treated with CPAP. Patients who were non-compliant with CPAP have also a greater risk of composite endpoint. We have talked about those before. Here, other studies that have shown that CPAP in central sleep apnea, this time with heart failure, reported an improvement in the apnea-hypopnea index, daytime plasma natriuretic peptide, catecholamine concentration, and improved LV ejection fraction. Also, CPAP improved in this study, apnea-hypopnea index, LV ejection fraction, 6-minute walking test, reduced plasma norepinephrine, but no difference in survival. This post hoc subgroup analysis suggested that there is a survival advantage in those with an 8 psi that was suppressed in less than 15 episodes per hour by CPAP. So people who, let's say, decrease their apnea-hypopnea index, it has been shown that they were improved. So here you have the episodes of apnea and hypopnea control group. You see that hypopneas and apneas decrease in people with CPAP use. Also, mean oxygen saturation, you see that with this CPAP use, we have an improvement in oxygen saturation compared to control group. The LV ejection fraction, there is an improvement with CPAP use, and also the minimum oxygen saturation improvement with CPAP use compared to controls. Another great topic, as I told you before, adaptive self-regulation. Remember that it's the future in not just since I'm a critical care doctor as well. It's not just the future in sleep. It's generally the future in mechanical ventilation. So adaptive central ventilation can improve cardiac diastolic function, improve symptoms, and decrease plasma brain natriuretic peptide. And preserved in people with preserved ejection fraction. As we said before, in people who have decreased ejection fraction with central sleep apnea and heart failure, we don't use adaptive self-ventilation. So always remember central sleep apnea, heart failure in people with normal ejection fraction, not with decreased. Adaptive self-ventilation and heart failure in sleep apnea. I have a study here. It shows improvement in all major echocardiography, A-wave, A-wave, LAD, E2A, and cardiopulmonary exercise test. So adaptive self-ventilation seems to improve all these factors, BNP, as we said before, the number of beats, echocardiography markers, and cardiopulmonary exercise testing. As I told you before, higher all-cause mortality in those treatment with adaptive self-ventilation due to sudden cardiac death. We are waiting the advanced heart failure study to explain us why this happened and maybe show us something that we don't know. And one of my last slides, the acute heart failure, acute decompensated heart failure. Central sleep apnea is found in most of patients with acute heart failure. It increases the risk of readmission and mortality. And adaptive self-ventilation, patient was limited but was terminated after the result of the shared heart failure. The study, as I told you before, regarding the increased mortality. So the take-home messages are always do severity grading, right? We have mild, moderate, and severe OSA. Remember that it's tier 5 apneas per hour. We are normal. 5 to 15, we are mild. 15 to 30, we are moderate, and more than 30, we have severe. Also, phenotyping, desaturation, time of desaturation, dipping during the night, it's important. Morbidity and probably mortality higher in non-treated than in treated patients, especially in more severe cases. Always remember that people with worse OSA, people with more than 30 apneas per hour, and you need to understand that 30 apneas per hour is you wake up every 2 minutes. So you cannot sleep at all during the night, first. And second, due to the desaturation you have during the night, that increases the inflammatory burden you have in your body. Sleep apnea also causes major cardiovascular outcomes, most of which can be prevented, especially in patients with good compliance. So compliance is something we want in patients. It has been shown, as I told you before, that people who are compliant more than 4 hours per night, they have better results compared to people who don't use it so often. CPAP is the gold standard, the most studied and validated treatment so far. There are other treatments. Unfortunately, I wish I have more time to explain you regarding the other treatments, but always remember CPAP. It's the gold standard. And also adaptive self-ventilation needs further evaluation. As I told you before, always remember that we use adaptive self-ventilation in central sleep apnea and heart failure, but in people with preserved ejection fraction. Thank you for your time, and I'm open to questions.
Thank you so much, sir, for your insight into this most important topic. We will go ahead and take some time for questions now. So any student having any questions can drop them into the chat box or can turn on your mic and interact directly with the sir.
Oh, most
Meanwhile,
of
please
them, they
fill out
have
the. Yes, sir.
they had the problem with the slides. I'm sorry about the slides. I had a problem with my computer. Something happened, and I used an old computer I had in Greece. I'm in Greece at the moment for holidays, so I have my computer in the United States. I don't know if you have any problem. Someone asks if OSA is treated by physiotherapy. Well, there are some studies that show that people who use, let's say, it's a certain kind of physiotherapy, they may that might be helpful, but mostly those studies are mostly in people with mild disease. So when we say mild, it's from 5 to 15 apnea hypopnea index per hour. So in severe disease, people with more than 30, the gold standard, as we said, is CPAP. There are many ways to treat sleep apnea, but the most validated and the most studied is OSA. So it's not perfect. Try to imagine having a machine, into your nose. It's quite stressful during the night, and that's why we say compliance. Compliance is a question in all people. Compliance is 60% maybe in people with OSA, no more than that. So 40% are untreated, and especially people with severe OSA. It has been shown that they have the worst outcomes, especially if they are untreated or partially treated. I hope that I answered your question. Please write any other questions if you have in the chat, and I will be happy to answer to all your questions. You can find my my mail online and send me if you have any questions or if you need any further guidance. Okay. I'm sorry for the slides. I'm sorry. Any other questions from the audience? Always remember people with resistance OSA, people who failed ablation. Always remember that 50% of people with hypertension have OSA. Always remember that people untreated for OSA, they have all major cardiovascular events. Always remember that CPAP helps OSA, especially in good compliance. So always look for OSA. Always look for sleepy people, right? Someone comes into your office. Doesn't matter if you are cardiologist, pulmonologist. Just look for OSA. It's it kills slowly during the night, and people cannot understand what's going on. They have mental problems apart from the cardiovascular problems. It causes every kind of disease, and that's due to desaturation.
Thank you so much, sir. Dear students, if you are having any questions, you can still type in the chat box. And meanwhile, please fill out the feedback form as it is mandatory for your certificates, as the link is connected to the document that possesses your certificates.
Are we done? Any other questions?
All right, if there are no questions, now I request Alagya Das sir to propose the vote of thanks. Over to you, sir.
Am I audible?
Yes, sir.
All right. A very good evening to one and all. And at first, my heartfelt thanks to our eminent guest speaker, Dr. Dimitrios Kantas. And I thank you for accepting my invitation for the interactive talk and research-oriented talk come webinar. And Dr. Kantas, the topic of your collection is so useful for all. Actually, day by day, increasing number of cardiovascular diseases and are a huge problem to the global healthcare system, and maximum people's diet worldwide suffering for whole cardiovascular disorders. And the main cause of obstructive is excess weight and obesity. And the main important things is that you share your knowledge in this topic was so impressive. And in 1 hour talk we will give the insight knowledge in very concise way. It was so remarkable and miraculous experience. And so thank you for sparing your precious time and share your valuable knowledge with us. And it's give me a immense pleasure to deliver a vote of thanks to our today's eminent guest speaker, Dr. Dimitrios Kantas, and also all the participants. Once again, I thank you for such an interesting, knowledgeable talk, and we are really thank you to you for sharing your expertise view with us. And I'm sure that all are liking it too. And it was our privilege that you are presented interesting talk that enlightened our body scientists and researchers. And I hope you will be able to make your presence in future events too. And we are so pleased to have you in between us. And I'm looking forward to organize more events in future also.
I'm really happy that I presented here. One last question someone has: it's possible that both male and female have same kind of risks from sleep apnea? Well, as I had the slide, well, it seems that women are protected from sleep apnea until their menopause. After that, they are pretty the same compared to men. And that's it. Thank you for your time. I really appreciate it, and hopefully we will collaborate in the future as well. Thank you for your time.
Yes, sure. We will definitely collaborate with many more events, and thank you so much for giving your precious time. And my heartfelt thanks to our organizers, event coordinators, Dr. Subhendu Bangopadhyay, Dr. Arpana Parihar, Dr. Ritu Chandel, Dr. Das, and our organizers, Ms. Ananya, Ms. Bharti Patnani, Mr. Shreyans, and also a big thank you to Dr. Subhendu and Ms. Bharti for a wonderful anchoring and welcoming guest and fruitfully handling a whole session. It's really a commendable. Thank you so much. And once again, all my dear students and researchers, thank you for joining and invest your precious time for listening the talk and support us. And last but not the least, on the behalf of Biosetup Life Sciences, I thank each and every one for contribution to make this webinar a successful one. And I'm looking forward to arranging many such events. Thank you all. Have a good day ahead. Good night.
Bye. Bye. Bye.
Bye bye.
Thank you, sir. Thank you, everyone. We appreciate you being here. For the participants, filling out the feedback form is mandatory for your certificates. The link is connected to the document that possesses your certificates. After filling up the feedback form, uh, a link will be shown there by clicking on which you will get the certificates. You have to find the certificates after clicking on that link.